All right, let's jump right in. Welcome to the Clinical Priority Playbook. Look, this isn't about memorizing textbook pages. This is about knowing what to do when things go sideways and every single second counts. So let's get into the concepts you absolutely have to nail down.
So here's our roadmap. First, we're going to decode shock syndromes. Then, we'll dive into how to respond in those critical, high-stakes emergencies. From there, we'll switch gears to the unique world of OB and newborn care. And we'll wrap it all up with a lightning round on meds, rules, and priorities. Let's do this.
Okay, first up, shock. You can think of it as a total body crisis where there's just not enough oxygen getting to the tissues. The absolute key here is spotting the pattern, recognizing what's happening before it spirals completely out of control.
We're going to start with the one you'll probably see most often, hypovolemic shock. To put it simply, the tank is running empty. Whether it's from bleeding or some other major fluid loss, the heart just doesn't have enough volume to pump. And if there's nothing to pump, your body's tissues are literally starving for oxygen. Now, this is what I find so fascinating, how the body tries to fight back. At first, it tries to compensate, so the heart rate and breathing speed up. Then you hit the compensatory stage. This is where you see the classic signs. The skin gets cool and clammy because blood's being shunted to the vital organs. The patient gets confused, and they stop making much urine. If you don't step in, it gets worse. The blood pressure finally tanks, and you might see these little pinpoint hemorrhages called petechiae. After that, it's irreversible. So that compensatory stage, that's your window. That's when you have to act. So how do you tell them apart when a patient is crashing? This right here is your cheat sheet. Now, pay attention. With hypovolemic and anaphylactic shock, you're usually going to see a fast heart rate. But look at neurogenic shock. It's the odd one out. You get bradycardia, a slow heart rate, paired with that dangerously low blood pressure. This will be on your exams for sure, but more importantly, it's a massive red flag in a real patient. And the priorities are different. Pour in the fluids for hypovolemic, get some huge IVs ready for neurogenic, and for anaphylactic shock, it's all about that life-saving epinephrine.
All right, let's build on that. We're moving into those critical emergencies where your very first decision can change everything. This is where thinking fast really matters. So, picture this. You're on the scene of a multi-casualty burn incident. You've got several patients who need you. Who do you go to first? Who is your number one priority? It is always the patient with facial burns. And why is that? It comes down to 3 letters. ABC. Airway, breathing, circulation. A burn on the face could mean a burn on the inside, in the airway. And that airway can swell shut so fast it'll terrify you. You have to get to that patient and protect their airway before it's gone. Okay, switching gears to a neuro emergency. When you've got increased pressure inside the skull, the brain is in serious trouble. There are a lot of signs that can pop up, but there's one that usually shows up first, and it's the one you absolutely cannot afford to miss. And here it is. The number one first sign is a decreasing level of consciousness. Now, I want to be really clear here. This doesn't mean your patient is passed out. It can be super subtle. We're talking about new irritability, a little restlessness, maybe some slight confusion. These are the whispers of a neurological storm that's about to hit. You see, by the time you get those textbook signs, like the slow heart rate and high blood pressure, that pressure is already critically high. Those are late, really bad signs. Catching that early, subtle change in their mental status is your best shot at making a difference. All right, how about this one? Snake bite. So much of what people think they know from movies is just dead wrong and dangerous. Here's the real deal. Do keep the extremity still to slow down the venom. Do get the anti-venom ready. A loose bandage is okay, but you do not apply a tourniquet. That can trap the venom and just kill the tissue. And forget about ice or heparin, and don't raise the limb above the heart. Okay, we're shifting gears big time now. Let's head over to OB and newborn care. This is a whole different ballgame where you're always taking care of 2 patients at the same time. If you're going into labor and delivery, you have to know veal chop. It's how you read a fetal heart monitor strip. It goes like this. If you see a variable decel, think cord compression. Your first move is to change mom's position. Early decel, that's just head compression, totally normal. Accelerations, that means the baby is okay. But late decels, that's the one that gets your attention. It means placental insufficiency. And your response has to be immediate. Stop the Pitocin, turn mom on her left side, give her some oxygen, and open up the IV fluids. Preeclampsia is one of the scariest complications of pregnancy. You're watching for early signs, like swelling in the hands, feet, and face. But you've got to be on high alert for the signs that it's getting worse. A headache that won't go away. pain right under the ribs, or changes in vision. Those are huge warning signs that a seizure could be coming. And while we do our best to manage it, you have to remember, the only real cure for preeclampsia is delivery. So, the baby's born. Now what? Well, one of your very first jobs is keeping that tiny human warm. And they can lose heat in 4 different ways: conduction from a cold surface, convection from a drafty room, radiation if they're near a cold window, and evaporation from their wet skin. And out of all of those, the single biggest threat right at the moment of birth is evaporation. That baby comes out wet, and as that fluid evaporates, it just sucks the heat right out of their little body. So what's your first, most important move to stop this? You dry that newborn. Thoroughly. It sounds so simple, but it is absolutely vital. And you can tell a lot just by looking at a newborn's skin. A preterm baby, one born a little early, is often covered in that white, cheesy stuff called vernix, and maybe some fine, downy hair called lanugo. But a post-term baby, one that's been hanging out a little too long, often has dry, cracked, almost peeling skin. It's a quick visual clue. All right, let's bring it on home. We're heading into our final section, a rapid review of some key meds, essential rules, and other priorities you just have to know. Delegation. This is huge. You have to know what you can and can't hand off. Your UAP, or unlicensed assistive personnel, can be a huge help. They can get blankets, help a patient to the bathroom, grab utensils, but what they can never do is anything that requires nursing judgment. Remember this, you cannot delegate what you can eat. EAT. Evaluate, assess, or teach. That belongs to the nurse. It's your license, your responsibility. Okay, let's talk about magnesium sulfate again. This is a high-alert drug, and there's a common misconception about it. Its main job, its primary purpose, is to prevent seizures in that patient with severe preeclampsia. It is not a blood pressure medication. Yeah, it might lower the blood pressure a little bit, but that's a side effect, not the reason we're giving it. And because MAG is a central nervous system depressant, you have to be watching for toxicity like a hawk. So you have a mental checklist going at all times. You're watching their breathing rate. You're checking their urine output, making sure it's more than 30 an hour. You're checking their deep tendon reflexes, because they'll start to disappear if the level gets too high. And of course, you're constantly assessing their mental status. This brings us to the Glasgow Coma Scale, the GCS. It's how we standardize assessing a patient's level of consciousness, on a scale from 3 to 15. Now, you don't have to have every single point memorized for this, but you need to know the #1 rule of the GCS. Any drop in the score, even if it's just by 1 single point, is a major change, and you have to report it immediately. And that leads us right to our final thought. Look, we have all these amazing tools, protocols, algorithms, and mnemonics, but in a world full of complex patients and situations that never quite follow the textbook, what is the one single clinical tool that you have to sharpen every single day? It's your own brain, your clinical judgment, your critical thinking. That's the thing that's truly going to save lives.